Welcome everyone to our virtual policy forum, Public Health and Delivery System, Vital Connections. I'm Tony Barrueta, Senior Vice President for Government Relations for Kaiser Permanente. I'll be your moderator for today's conversation, hosted by the Kaiser Permanente Institute for Health Policy. The Institute hosts events and publishes information to help shape policy and practice on important health topics. We often convene experts to share knowledge, spark discourse, advance collective thinking, and explore opportunities to cultivate healthy communities and promote more accessible, high-quality healthcare. This is the first forum in a two-part series. Today's conversation focuses on health department and delivery system leaders' experiences during the pandemic and what they have learned over the past 2 years. We'll explore together both successes and challenges and what these experiences tell us about what's needed to build a more effective public health system going forward. In part 2, on December 2nd, Thursday, we'll continue this conversation focusing on the future of public health and public policy needs and opportunities. So we're very glad you could join us today, and I'm looking forward to an engaging conversation with our excellent speakers. Okay, a couple of housekeeping points at first. After panelist remarks and a brief panel discussion, we'll take questions from the audience. You can submit questions through the Ask a Question box on your screen at any point during the forum. We won't have time to get to every question, but we'll do our best to get to as many as possible. If at any point you experience technical difficulties, please let us know by sending a message in the Ask a Question box. This event is being recorded, and the video will be made available on the Institute for Health Policy's website within the next couple of weeks. Okay, so let's get started with the forum. For all of us, and certainly those of us who work in health systems and public health agencies, the past 2 years have clearly been a very difficult, quite incredible challenge. We've been tested in ways we might never have imagined. We've tried to bring our best selves to those challenges, and we've learned from the process. We also know that these challenges will continue, as we see from the discussions of the past several days on the latest COVID-19 variant. We are all responding constantly to an evolving pandemic. As information changes, our responses change, and we know this will continue in the coming months. So to kick off our conversation today, I'm very pleased to turn to Greg Adams, the Chair and Chief Executive Officer of Kaiser Foundation Health Plan and Hospitals. Greg brings over 30 years of leadership experience as a senior healthcare executive, and we've benefited during the pandemic from his deep leadership experience responding in real time to the impacts of COVID-19 across our health system and in our communities. So Greg, thank you so much for joining us. We're honored to have you to open up our important conversation today. I'm going to turn it over to you.
Thank you, Tony, and good morning, everyone. It's great to be here and to be a part of such an important discussion. We're here today to elevate the conversation, to elevate the perspectives of leaders in the field of public health and care delivery, to share our experiences navigating the pandemic, to discuss ways we can break down the barriers we all face, and to think about how we can promote and improve our public health system together. You know, I grew up in the South as a young kid with limited resources, and the public health system was a very large and huge, important part of my life. My family, my parents didn't have access to care delivery systems the way we know them today. And I remember as a young child sitting in a nurse's office in the public health department, receiving a shot and talking about my health. The public health system began in the 1700s to improve our sailors' health and has evolved over time to include health education, sanitation, and data tracking. The responsibilities of our public health system continued throughout the 20th century because of the importance of recognizing how the system helped us to mitigate health threats. In fact, for so many years, the American public health system was the envy of other countries. But as we all know, that has changed over the last several decades. Our public health system began to rank lower and lower on the nation's financial priority list. While the United States spends more than $3.6 trillion annually on health, less than 3% of that spending is directed toward public health or prevention. For decades, we've failed to invest in our public health system, which has stretched and thinned our public health workers and our programs. According to the Kaiser Health News, nearly 2/3 of Americans live in counties that spend more than twice as much on policing than on public health programs and non-hospital health care. When COVID hit, public health policy leaders did their best to make do with what has been fundamentally, for decades, an underinvested system. By not investing in public health, a necessary government function, and not treating it as a critical core institution in our society, there has been irreversible damage, and the pandemic was made vastly worse by a lack of resources. The last 21 months have challenged and tested us all, and we have much to learn from the experience we have faced together. Public health and delivery systems have dealt with unprecedented challenges during this pandemic. These have included figuring out how to fight this novel virus and how to get people vaccinated, keeping our frontline staff safe and healthy, and continuing today even to deal with the exhaustion and the burnout. Having data-driven decisions hindered with the inability to share data when the pandemic started. And of course, the delay of preventative care and treatment for other diseases, since we've had to shift our focus to combating this pandemic, which we hope would be over by now. Additionally, our public health systems and our public health departments have been faced with critical staffing shortages that we're also beginning to see in our healthcare delivery system. All of these making it harder to respond to the continuing needs and leaving us less prepared to respond to future health challenges. It's critical that we begin to solve these challenges. The private and public sectors must work together to find ways for public systems, the medical community, and private entities to collaborate more effectively. Coordinate among public and private sectors around common goals to impact health, and gain commitment not only from the public health community and the healthcare systems, but also from other sectors, including the business community. The business community responded in important ways during this pandemic, like requiring employee vaccination, but their strong and consistent engagement in public health will be needed in the long term if we are to strengthen and bring the resources into the system that's necessary to provide what we should be providing today and to be prepared for future pandemics and future challenges to our health. We must also develop longer-term strategies for investing in healthy communities to address upstream factors, including poverty, housing, and other social determinants of health. And we must work together to find opportunities for both mental health and community health services. We at Kaiser Permanente believe in the importance of an effective, well-funded, well-coordinated public health system that can promote good health for all. To be clear, we must increase the funding to strengthen the public health infrastructure and workforce. As a country, we must own and recognize the true value in a strong, robust, and supported public health system. The question for today's discussion and for the next part of this series that takes place on December 2nd is, how do we reach this goal? How can the public and private sector work together to meet the needs of and promote the health of our communities? What is the role of public policy in advancing public health now and in the future? As we look to the future, we can learn from the challenges and successes of the pandemic response to proactively build a stronger system in the future. I have hope that we can begin to answer these questions together as we discuss the opportunities to strengthen partnerships, name the barriers, and identify policy solutions to improve our public health system, address health needs, and advance health equity. Thank you to the panel. Thank you to all of our participants for joining us today. I look forward to this robust conversation today and to a continuation of the dialogue on December 2nd. Thank you. Back to you, Tony.
Thanks so much, Greg. And, I just reflecting on your comments, Greg, one of the things that's been remarkable has been your personal, very active engagement with the public health community, even as you've been leading an extraordinary response of the health system to provide the services that have been necessary inside this. So, Greg, thanks again for your leadership in this space. There's a ton more work to do, but I know we're committed to doing that moving forward. So thank you, Greg. Let's go ahead and hear some additional experiences and reflections from the public health and health system leaders we've got here today. So let me bring up today's panel. Unfortunately, Dr. Jeff Duchin had a last-minute conflict and was unable to join us today, but we're thrilled to hear from another public health expert also hailing from the Seattle area. So Patty Hayes, former director for public health for Seattle and King County, thank you so much for making yourself available this morning on very short notice. It's going to be wonderful to have you here today. Also joining us is Dr. Megan Ranney, emergency physician and incoming academic dean at Brown University School of Public Health. Welcome, Megan. Dr. Oxiris Barbot, senior fellow for public health and social justice at the JPB Foundation and former health commissioner in New York City. And my colleague, Dr. Stephen Parodi, executive vice president for the Permanente Federation here at Kaiser Permanente. So our first speaker this morning is going to be Dr. Ranney. She is an emergency physician, researcher, and national advocate for innovative approaches to public health. She's a professor of emergency medicine at Alpert Medical School at Brown University, and she's founding director of the Brown Lifespan Center for Digital Health. She's also incoming academic dean at the School of Public Health at Brown University and a member of the Aspen Global Leadership Network. She's also president of the board of GetUsPPE.org. Her federally funded research focuses on developing, testing, and disseminating digital health interventions to prevent violence and mental illness. So Dr. Ranney, thank you so much for joining us. I'll turn it over to you.
Thank you so much, Tony, and a huge thank you to Greg as well for creating this forum and for welcoming us today. So you had asked us to chat over about 5 minutes about what we're learning in real time, and if we could rewrite the script on COVID, what would we do? And I feel like we have the chance right now with Omicron to think back and apply the lessons that we've all learned over the last 20 months in real time. So I frequently say, from my perspective as an emergency physician, that COVID really turned over the rock and showed all the creepy crawlies underneath the surface that those of us in healthcare and public health have known were always there, but that stayed hidden from most of the rest of society. Whether it is the impact of structural racism on both health and healthcare, whether it's the supply chain challenges, the consistent overcrowding of our emergency departments, or the lack of national focus on prevention. These are problems that many of us have been trying to call attention to for decades, but we saw in stark relief during COVID. So when I look back on the past 20 months on both what we did well and what we could do better, I see those falling within a few basic themes related to those consistent issues in healthcare and public health. The first thing that I saw as both a strength and a weakness of our response to COVID was that failure was not an option. Healthcare is known for being tremendously slow to change, as is public health, but COVID forced us to move quickly. I think back to the beginning of the pandemic when I was filling out forms for COVID tests using paper forms and then faxing them to my Department of Health to get permission to do a test, waiting for a swab, and then waiting for a fax back of results 2 to 3 days later. I compare that to what we developed over the course of the pandemic through cooperation with companies like CVS and Salesforce, as well as other publicly and non-publicly traded companies that have revolutionized our Department of Health here in Rhode Island in terms of our ability to track data around COVID and many of its corollaries around demographics, race, ethnicity, socioeconomic status, geographic area. That force into quick innovation and that force into collaboration with private entities was both a strength and a potential weakness of our public health response. And if I could do it over, I would grow that more quickly. I would build up that data system. And I think it's essential as we go forwards, again, as we think about Omicron, which I know is part of the reason that Jeff couldn't be here today. The second and related thing that I feel we learned so strongly over the last 20 months is, to put a finer point on it, that need for data. As you mentioned, Tony, I created an organization called Get Us PPE, a nonprofit that was dedicated to getting donated personal protective equipment, originally from the basements or kind of back offices of folks across the country during the early days of the pandemic, and then later through cooperation with businesses and larger companies, getting that into the hands of those who needed it most. In the early days, it was all about acute care workers, but as the pandemic dragged on, we actually began to focus mostly on home healthcare aides, nursing home workers, senior daycares, those adjuncts to the healthcare system that are forgotten and that are still not included in national estimates of needs for personal protective equipment. That's one small example of where we desperately need better data, both to guide us today and to guide us tomorrow. So that would be the second thing I'd do differently. The third is around communication and misinformation. I've been privileged enough to be a frequent commentator on national media over the last year and a half. I've done it not with formal training, but kind of by trial and error. And I think I made some mistakes along the way. And we've seen the results of targeted disinformation and misinformation campaigns over the last year and a half. So if I could go back and do it over, I would provide greater training to our entire public health workforce about how to better communicate and how to combat some of those forces of myths and frank lies that have dominated much of the public health discussion and distracted us from doing the real work. And again, we're seeing it even today with Omicron. The final thing that I want to emphasize, and knowing that I have only 5 minutes to talk, but hopefully we'll get more chances to discuss this, is around the need to talk about the other epidemics that coexist with COVID. I got asked yesterday about what our COVID situation is in our hospitals. And I'm like, we don't have many cases here in Rhode Island. Our vaccination rates are great. It's gone up, but it's not horrible. But we do have our emergency departments and hospitals that are absolutely overwhelmed with people that put off preventive care, taking care of thyrotoxicosis, DKA, sepsis, advanced cancer. I could go, opioid overdoses are up, and certainly our gun violence is through the roof. Those are all things that existed pre-pandemic, but that we largely stopped paying attention to. And I wish that we could go back and do better. I think we have a chance now to readdress resources to those other co-occurring epidemics that preceded the pandemic and will post-date it, and that will have a deep impact on our healthcare systems and public health going forwards. I'll stop there and look forward to the discussion of the other panelists.
Thanks, Dr. Ranney. Lots of great stuff in there, and we will get back to some of those issues. We should have plenty of time to discuss some of that. So our next speaker is Dr. Oxiris Barbot. Dr. Barbot is a physician, public health practitioner, an innovative leader in the intersection of public health, social justice, and healthcare delivery. She's currently Senior Fellow for Public Health and Social Justice at the JPB Foundation. And prior to that role, she was Health Commissioner for New York City and Baltimore City prior to that. As the former Health Commissioner for New York City, Dr. Barbot was instrumental in directing the city's response to the first wave of COVID by taking science-informed actions to flatten the transmission curve and address racial inequities. Dr. Barbot, thank you so much for being with us today.
Thank you. It's a pleasure to be with you all and to be with such an esteemed panel. So I'm going to take my comments in a little bit different direction than Dr. Ranney. As you mentioned, I had the honor of leading the New York City Health Department during the first wave of COVID and during the time when the country was experiencing mass demonstrations against police violence and racism after Mr. George Floyd's murder. These were the 7 most intense months for public health in the last 100 years. And I had a front row seat to the good, the bad, and the ugly in our public health and healthcare delivery systems. And so what was clearest to me is that it's never been more important to have a strong public health system. And this was really crystallized by the trust that New Yorkers had in our public health guidance during that first wave response, when very little was known about this virus. And this trust was cultivated through years of high quality public health work that had been done by the health department going back generations. And this level of trust is best exemplified by high levels of compliance with mask mandates that we put in place starting on March 31st, 2020. And I wish I had ordered mask mandates sooner, but I'm glad that despite that lag, New Yorkers took the call to heart and were consistent in their usage. Not perfect, but consistent. And I recall lots of people outside of the city commenting that there was a distinct difference between the way in which New Yorkers adhered to mask mandates as compared to the rest of the country. And it was really that adherence to mask use that was critical in flattening our transmission curve and keeping us from having peaks and subsequent waves that were anywhere near as high as that first wave. And so I think our country's collective transmission curve would have and could have been very different if that guidance was followed, even in places that hadn't yet seen their first official cases. And then I think now, as with the emergence of Omicron, we have an opportunity to do a reset on ensuring that we have mask adherence consistently throughout all of our country. And so during this early period, our city was well served by the quality and the strength of the partnerships we had built with our healthcare delivery partners over the years, starting back with the response to 9/11. And this was especially true in January and February of 2020, when it came time to determine which hospitals would be first called for incoming patients suspected of having COVID. And as the intensity of the response went through the roof, so too did the challenges. There was an imbalance of where patients were treated because there was a reluctance to transfer patients to different health systems because of revenue concerns. There were also power plays to capitalize on the dysfunction between the mayor and the governor. And lastly, I think there was also a lot of hubris on the part of healthcare delivery systems, thinking that they could outperform the virus, thereby giving politicians false hope that they didn't need to listen to public health. And so some of my biggest concerns moving forward is the following. We have an incredibly dedicated public health workforce that poured itself into this response, but that are now demoralized and leaving in droves because in a year and a half, they've been incessantly berated and vilified to meet political ends. And the big potential ugly here is that elected officials are installing new public health leadership that my fear is will be much less likely to stand up to things that don't follow science. And that it may cost more lives, not only for COVID, but for whatever the next crisis is. And that this will further erode public trust that took so long to cultivate. And the bad here is also that I haven't really heard very many leaders of healthcare delivery systems expressing concerns publicly about where that may be leading our country, because I suspect that they're deep in the throes of overburdened hospitals and dealing with challenges of keeping demoralized and traumatized people on staff. And what I think this country desperately needs moving forward is public health, is leaders in public health and healthcare delivery to align and take a stand publicly on what we need the American public to do to bring this pandemic to an end. Additionally, we need to reestablish the trust of public health and an appreciation for the value that it plays in all aspects of our everyday lives. It's embarrassing that we've let this pandemic devolve into a red versus blue issue, and where it feels like we're losing the battle between individualism and collectivism. But I remain hopeful that in spite of all that's gone wrong, we can break out of this death spiral of divisiveness. But clearly, we need a hard reset. We need leaders who are asking questions and taking actions driven by an equity perspective and not a partisan perspective. Leaders that are interested in bringing us together towards the values of collectivism and not maintaining the status quo, which continues bolstering structural inequities built on a false narrative of individualism and in fact only favors the few over the many. So I thank you for this time, and I look forward to the rest of the speakers' remarks and a lively conversation.
Thank Thank you, Dr. Barbot. Lots of interesting commentary in there that we'll definitely want to come back to, because I think you've really hit on some of the divisions that we're suffering from in our society, and need to figure out how our health systems and public health can figure out how to speak to everyone. It's going to be important. So thank you. Our next speaker is Patty Hayes. Patty is the former director of public health, Seattle and King County. She has over 35 years of experience in public health and policy. Previously, Patty was executive director of a statewide nonprofit, Within Reach, which assists families and individuals to access health and food resources. She's held a number of positions at the state health department, including assistant secretary for community and family health and director of policy, legislative, and constituent relations. Patty has her nursing degree and master's degree from the University of Washington. In October of this year, the King County Council awarded Patty the Martin Luther King Medal of Distinction for her leadership during the pandemic. Patty retired from Public Health Seattle and King County on October 1st of this year. So Patty, congratulations on your award and your retirement, and thank you for joining us today.
Well, thank you so much. It's such an honor to be here. I'm so appreciative of this opportunity, and this distinguished panel is just great. So I want to pick up on some of the themes you're hearing and share from the King County and Washington State perspective. So I think two things I'll say just that run through everything, and the points I'm going to make is that we really need to work together on communication. And you've heard this from both of the speakers. And also this idea of how we be innovative and nimble together. We have to figure that out. So those two main things I just want to set out that will run through my four major points I want to make. So King County was the epicenter at the very beginning, and let me start there because one of the things I want to lift up is the long-term care system. I was actually in Washington, D.C. finishing a meeting of local public health leaders when I got the call that Life Care had a large outbreak. By the time I got back, we were successful in getting CDC out to Washington State, out to King County within 48 hours. We had a team out. That was remarkable in that not only did that assist us because we desperately needed the infrastructure, but it also created the space where the initial protocols for COVID were developed right here. What I'll say is that the role of public health became very prominent and sort of wasn't hidden anymore. And I think we need to really over time continue, and I so appreciate the comments and the need to really focus on the public health workforce and public health funding, because the response coordination responsibility that public health has, our responsibility to look beyond the healthcare delivery system and how the healthcare delivery system fits with other systems, our role as a backstop in areas such as homelessness and school and childcare, all of that has had really great examples and really troubling stumbles along the way. But in the long-term care area, we have got to figure out some basic issues with how we deal with infection control better. The health department did not have a good infection control infrastructure, and I will say that the long-term care system did not have a good infection control system. So we jumped into that space, and that is definitely one where the hospital and healthcare delivery system has a much better knowledge of the space we need to build off of. The jurisdictional challenges are great in this. What is the role that we want the federal government to play? What is the role that we want the state to play? And of course, the local health department is going to know and understand its local environment, its local population. And how do we respect that and build off that and make sure that funding comes to that local health department to build the infrastructure that it needs? We've already mentioned data systems, and I'll say that we've come a long ways, but we have a long ways to. We were lucky at Public Health Seattle King County to have a data system and help from partners here that we actually kept improving and turning on a dime so that the data was very consumer oriented, very oriented, so that local elected officials could see and look and interact with their data. We need to build off that. It's got to be faster. The willingness of hospital systems to share data needs to continually be addressed. And then it takes forever with the state to get data agreements. We have to address that. The partnerships became one of the hallmarks here in King County. I have a deep love for Kaiser Permanente because they were one of my first and best partners. We had deep relationships with all hospitals. We were lucky to have our Northwest Regional Healthcare Response Preparedness group that was the hospitals and the rest of the system and public health meeting together. But it really was Kaiser who came and worked, and I hope I have more time to talk about the workforce issues that Kaiser helped us with. Setting up testing systems, the very first to set up a large vaccination site that went beyond their own patients and clients. Really just wonderful examples. And then, as Dr. Barbot said, the whole issue of structural racism and the disparities that we've seen and the need to address, as we heard, the dual pandemics that are going on. This has got a core piece of work that we can do together as a system. It can't be just public health. It can't just be the healthcare system. We all have to come together with this because the long time disparities in things like maternal child health is unconscionable to me. And public health's been working to address this, but we need the partnerships and we need the continued attention on it. So I look forward to the conversation later.
Great. Thanks so much, Patty. And from the Kaiser Permanente perspective, I also have to say that I know our teams in Seattle were just found the local official, you and the other local officials, just tremendous partners as well. So happy to dig into how good relationships look in this context. Our final speaker is Dr. Stephen Parodi. Dr. Parodi is Executive Vice President of External Affairs, Communications, and Brand at the Permanente Federation here at Kaiser Permanente. He's also an associate executive director for the Permanente Medical Group with responsibility for hospital operations, inpatient quality, patient safety, care of complex and special needs populations, skilled nursing facilities, home health, hospice, and advanced analytics. And even with that long list, it didn't include he works very closely as my counterpart in public policy in the organization. So he's a fellow in the Infectious Disease Society of America and has served on the Society for Healthcare Epidemiology of America committees related to public policy, government affairs, and antimicrobial stewardship. Dr. Parodi, thank you for joining us.
Hey, thank you, Tony. And it's a real pleasure to join this panel. And I have to disclose that I was raised by a public health nurse, so I have heard both the extolled virtues and limitations of the public health system since growing up. But I want to sort of restrict my comments to a few things. So one is the communication between public health and the health systems. The second is communications with the general public and how we can coordinate better. The third is the digital divide between public health and the health systems and how we need to do better. And then the equity lens. And I think Dr. Ranney touched on this, the juggling between, quote, regular care and pandemic response, which I think is going to be our coming reality. When it comes to communicating with each other, of course, we mobilize and put together mitigation, surge, testing, vaccination playbooks, and made the early decision to share. And that was key. I think it was important. And public health was willing to share. So a lot of those sort of existing relationships that we had that were behind the scenes became very much into focus. And there was a lot of offline and online conversation. And hopefully we can build upon that and actually formalize some of those what had been offline sort of personal relationships so that they're more formalized going forward. And I really mean that at both the state and local levels, which I think had pre-existed, but also at the federal level, because again, the messaging between the different levels of public health would benefit from additional sort of coordination, because the health systems end up having to juggle all of those different realities and different recommendations that we're getting. When it comes to communicating with the general public, I think that there's an opportunity here for us, as Dr. Ranney was actually kind of referencing, a little bit of trial by fire. I also got to speak on a few national networks and that type of thing. And, interestingly enough, there was sort of a lot of emphasis early on in the pandemic about the science, the facts. And what I've learned, at least through this trial, is that facts are malleable, unfortunately. And so there's actually a need for public health and for health systems to be out there, not just talking about the science and the facts, but actually appealing to the emotions, to what actually really matters to people. And we need to be on social in a big way, and we need to do it in a coordinated fashion, and this actually has happened with a little bit of the vaccination campaign, where we've been working with the various state level officials and local officials to say, what are you going to say? When are you going to say it? And then when do you need us to be saying something? And who are we saying it to? And do you want us to be messaging to our patients in the exam rooms? Do you want us to be messaging to a community? Should we be working with a community benefit organization? What does that look like? But to have that level of coordination to combat disinformation, I think is going to be key. Let me talk about the digital divide, because that, is a real, we were talking about fax machines. The fax machines, actually, we had to buy a couple of fax machines for a couple of public health departments that didn't have ones that were working. And believe it or not, it's hard to actually find a fax machine. I mean, we need to, resolve that issue. But more importantly, the ability to exchange information in a way that is bi-directional. So public health has the broader picture of what's going on in a community, and health systems need to have access to that information. And of course, the only way public health can have that broader view is that all of us are exchanging the information directly. So rather than each county requesting its own form of information, how can we do this in a more uniform manner? Equity, being able to look at access to care from an equity lens, access to vaccination, all of those things, and how do we message to different groups of people so that it resonates. And again, we coordinate that messaging with public health, I think is a huge opportunity. We saw within one of our own studies at KP that if you're Black, Brown, Asian, Hispanic, you were more likely to be infected with the virus. Once you finally got into the four walls of one of our facilities, the actual mortality erased. But we need to be moving out into the communities. We can't be waiting for people to be piling up into our hospitals to address these issues. And then the last thing I just want to comment on here is that, we've got Omicron on the horizon. We're going to have other variants. We, by the way, have flu variants every single year. We've got to figure out how to take care of people's regular issues at the same time that we're juggling a public health response. And so being able to message that and actually have the operations in place to coordinate that, I think is going to be key going into 2022 and 2023. Thanks, Tony.
Thanks, Steve. Really helpful comments. And we could spend a lot of time talking about a lot of different things today. And fortunately, we've got a little bit of time to talk about a few of these things. But I really appreciated, many of the common themes all of you shared around, particularly trust and confidence in the public health system and the erosion of that, and the need to continue to cultivate it and mind it, communicating both with the public and across the health system and the public health system as being really critical, and simply being nimble, as Patty said, being nimble and innovative as we move forward. But let me start a little bit in terms of our discussion on relationships. I want to get to that. I think what we've seen has been a range of positive to negative relationships across the system. Many of them have been excellent. Many of them have been challenged. And a lot of that, I think, has to do with not having faced an urgent public health crisis in the form of an infectious, since HIV was a different type of crisis and, enormously critical and shaping of many people's careers and lives and understanding of the system. And then we went through a period in public health of thinking about non-infectious disease, essentially, and other factors. You could, maybe Patty, do you want to start with, what it took to maintain those relationships and cultivate the relationships across the health sector, public health and healthcare delivery, and where you think there might be lessons for areas that have had bigger challenges with that?
Sure. Thanks, Tony. First thing I would say is that relationships aren't something that are created in an instant, and an emergency is not necessarily the best time to try and make relationships because people are so focused and distracted at the same time. And what I'll say is that I think all leaders across the public health and healthcare system need to really look at how do they expect their organization to step into building of relationships across the system. I'm fortunate here in King County that we had worked on relationship building across the system for many years. It wasn't perfect, but there was a lot of ability to go ahead and have hard conversations and to have staff deployed to either public health or another system, sharing of resources that we got to, so that when we called, it would happen. Two examples I'll give are, number one, we were facing a critical shortage within our call center in public health. We were needing hundreds of new public health workers coming in to help us manage different parts of the outbreak. At the same time, I heard that the University of Washington School of Nursing had lost all of its placements for its students early on in the pandemic because the hospitals had to do, and the nursing homes had to do what they had to do, which was concentrate on their system. So I drove up to the University of Washington, met with the dean and her leadership team, and within 48 hours, we had deployed the entire undergraduate nursing program into our call center. This was both a miracle, we were able to do it, and it sort of drove everybody's attorneys really crazy, but we did the right thing, and it was a miracle because those students were able to graduate on time, because they were preparing to not graduate these students on time. And then secondly, it was an amazing thing for the public here. But the infrastructure to manage that isn't there. We should have a look at what infrastructure do we need. The second one I'll give is, as we set up our initial systems, one we called an assessment and recovery center, which was early on in the pandemic, and then we moved into isolation and quarantine centers. There is a wonderful example of how health systems work with public health to plan those, to staff those, do shared staffing. Even though the systems have different union structures, those systems were able to be established quickly and to be staffed because both the health department and particularly Kaiser really led the way in showing how to do that. And I hope that really gets written up somewhere so that other areas of the healthcare system can learn from that. Those two examples on partnerships were really, really important. There's an equity component in here, but I'll hold that, Tony, for another question.
Sounds great. Dr. Barbot, I don't know if you want to reflect at all on this from your experiences in New York. It was a different environment and equally challenged, if not more so. Thoughts on that?
Yeah, I was thinking as Patty was talking that the relationships we had cultivated over the years that really were supported in part by federal funding to do emergency preparedness training really came into play. I think the challenge during those exercises is really wondering whether people will step up to whatever that emergency is. And COVID, especially in the early period, showed how more than willing health systems were to really step into the challenge, and the fact that we had an existing infrastructure to meet that was incredibly important, because there was no time to spare, right? We had to have job specs already done for people to move into. I think the only thing that I will add in addition is that it's been an incredible example of having to, walk and chew gum at the same time, right? Because the world doesn't stop, emergencies still happen, and demonstrating that there's a role for everyone to play and everyone's role is equally important in this.
It's very helpful. Dr. Ranney, thoughts on this and the relationship maintenance? And
I think we saw both the strength of existing relationships and the dangers when they weren't there already. I look at my own state of Rhode Island. Our director of our Department of Health, Dr. Nicole Alexander Scott, very early in her tenure as director, had set up health equity zones across the state where she and our Department of Health worked very closely with some of our communities with some of the worst health outcomes to help put in place solutions that worked for them, that identified and responded to problems that they thought were important around public health and healthcare. It was through those years of partnership, exactly what Patty and Dr. Barbot identified. It was through those existing years of partnership that when the pandemic hit, we were able to very quickly gain the trust of those communities, whether deploying, we were one of the first states to set up walk-through COVID testing as opposed to drive-through, because through our HES, we identified that a lot of folks in some of the higher risk neighborhoods didn't, of course, have access to a car. And so although drive-through testing was great and protected the folks that were doing the tests, it didn't actually help the communities that were at highest risk. Later in the pandemic, when vaccines became available, Dr. Nicole Alexander Scott worked with those communities to roll out vaccines to our elderly, to our healthcare workers, to our nursing home residents, and to the residents of some of those hardest hit communities, including Central Falls, which is 1 square mile, one of our poorest communities in the state, one of the highest rates of COVID infections, hospitalization, and death in the state. And we went door to door to these multi-generational homes to offer vaccines. Would not have been possible if we hadn't already had the trust. On the other side of the spectrum are the places where we didn't have trust, and we're seeing that play out right now across the country. Some places in my home state of Rhode Island, but certainly in other places that I've been working as well. And I think we've seen that destruction of trust very clearly in our nursing home and home healthcare aides, who have been some of the healthcare groups that have had the slowest uptake of vaccines. I think it's because we didn't provide them with PPE, because we didn't respect their safety fears early on. And I think that the hen is coming home to roost from lack of attention to some of those communities' very real needs early in the pandemic. I hope that going forwards, we put greater emphasis on, it's tough, as you both Patty and Dr. Barbot said, right? We were kind of both rushing, we've been in this situation where it's like we have to rush and do the best we can. You can't always take time for full consensus, but it's where those establishment of relationships early on allows you to respond quickly and to pivot as needed.
Steve, I don't know if you want to comment on that at all. I know you are in a unique position of having to deal with multiple jurisdictions on behalf of the delivery system, and it's a little bit of different experience to have to juggle all of that.
Yeah, I want to comment on public health. I mean, they've got a tough job, right? So it's not like there's one health system within a given community. There are multiple health systems, and they're trying to talk to multiple different groups. And ideally, particularly in this situation with all the misinformation, you want the policy to be relatively uniform, ideally. And so in some cases, we actually leveraged our trade organizations. So where there was a medical association or hospital association, instead of making public health call every single system separately, we said, why don't we actually have all the systems on at the same time? That's novel. And then let's have public health there at the same time. And then let's talk it through together. That was, I think, really powerful because it broke down a number of different barriers or silos between health systems. So we were able to sort of coordinate, okay, what are you going to do with the employee policy? Who's off, who's on, depending on a positive test, that type of stuff. The second thing is that the health systems have these leveraged relationships with, either other payers. For example, the private sector, we work with employers. A number of the employers weren't doing stuff. So they were like, well, we can make PPE. We can do this for you. And being able to coordinate that and making that transparent to public health so that we could actually help and plug holes where they were. Pushing the vaccination message. Again, public health has the mantle to be able to go out there and say, this is what we think is right. And then, leveraging the health system's relationships with employers like the Business Roundtable to say, okay, can you actually augment, support, or actually put into policy in the private sector exactly what they're doing in the public sector. And then the last thing I'll comment on, because it's a really important point here that was made earlier around infection control and skilled nursing facilities. And I'll take it one step further besides skilled nursing facilities. There are these, it wasn't on my radar before this pandemic, which were residential care facilities for the elderly. So they're not SNFs, but there are a ton of people, actually a lot more people in those facilities than there are SNFs, and they're just as high a risk. And so, we actually helped augment the public health response by actually going in and teaching infection control, literally to people. And by the way, they don't have infection control nurses. So you got to teach other people how to do infection control. And then sharing that information with public health so that can be disseminated. So it was really an opportunity to take skill sets that exist within the whole health ecosystem that we have siloed as this is healthcare delivery, this is public health, and to say, no, actually, we need to be able to share and do it systematically. I think that's the opportunity. Patty referenced this here earlier. There isn't infrastructure right now to do so, but we need to invest in it.
No, great points. I'm torn on which direction to go with my next question because all of you talked about the challenges of communication and particularly the misinformation that's come up and how do we attend to that? And I do want to invite all of you to comment on your views on how we can make progress in that direction. I want to start though with Dr. Barbot, where you had mentioned, and it's interesting because there is a philosophical and political kind of problem in this space, which is ultimately results in a communication problem. And I thought you touched on it really nicely on the individualism versus collectivism point. And I wanted to invite you to say a little bit more about that because it is exactly what goes to as a legislative and policy advocate, figuring out how to communicate to the different audiences in a way that's persuasive is extremely challenging. Some of that is rooted in these underlying views. So could you talk a little bit more about that problem and how you see we might be able to make some progress in that direction and how it ties to communicating more effectively?
Yeah, thank you for that. I've been reflecting a lot on sort of the bigger picture issues that really influenced the first wave of the response. And if I can boil it down to sort of one sentence that just sort of encapsulates what I'm thinking about, it's the saying that culture eats strategy for breakfast. In this situation, culture ate strategy for breakfast, lunch, and dinner, and a midnight snack, right? Because you could do all the planning in the world, but if you don't really take into consideration the larger cultural issues that influence how people look at disease and look at emergencies, then you're going to be spinning your wheels, which I think is a lot of what we did early on. And so this issue of collectivism versus individualism, I think, is at the heart of what our issues have been as a country, and the tension between, I want to have my liberties and we need to wear masks not only to protect ourselves, but to protect our communities. And so there have been a lot of interesting studies that have been done lately examining the influence of individualism and collectivism on COVID outcomes at the country and state levels. And just to sort of, level set, collectivism is characterized by the view of an interdependent self. So it captures the tendency to be more concerned with the group needs than with the individualistic interest. And individualism captures the tendency to be more concerned with one own's needs, right? And so people who live in collectivistic cultures are more likely to agree with statements of my happiness depends very much on the happiness of those around me, whereas people who live in individualistic cultures tend to agree with statements about what happens to me is my own doing. And so to summarize the findings of these studies, among the most relevant covariates, accustomed freedom of assembly and association and agency, were found to be associated with increased COVID transmission speed, right? And countries with more individualistic cultures had more cases and deaths. But there was one study in particular that was conducted in the US and looked at state level and county level data and found that states and counties with increased collectivism saw higher mask use, even when you controlled for demographic variables, COVID severity, government stringency, population density, income per capita, and most importantly, political affiliation. Right. So part of my concern is that we're letting ourselves fall into the trap set by others in terms of this political narrative that it's red against blue when it's not, right? It's about all of us as Americans taking care of one another. And so I think the challenge for us, and I don't necessarily have the answer, but the challenge for us is how do we get back to the values of collectivism, right? The values that help us beat smallpox, the values that helped us beat polio, the values that helped us be the country that we are. And so I don't want that to get lost in the narrative and for us to seed that to others who are talking heads and who, get increased likes and increased viewership by the more sort of belligerent and provocative that they are. I think we need to have people in public media, whether it be social media or TV, such as, Dr. Ranney and others on this panel, who can speak to how do we bring us back together and draw on that collectivism as our strength, right? How do we make that our superhero power once again?
Okay, Dr. Ranney, the challenge has been thrown down that you're the one who's going to solve this. So how do we move forward here?
Oh, piece of cake. No, just kidding. I wish I had a single answer. I mean, I really think there's a few things. So the first is, I do think that training our health and public health community in how to communicate is critical. I was having a conversation this morning around, we've been caught in crisis communication, but what I'm watching happen, particularly around Omicron, is like this outrage, right? Outrage that we're back here again, that on the one side of the aisle, it's folks saying, how dare there be another variant? This is an excuse to control us. On the other side of the aisle, it's how can we not have mask mandates everywhere right now, right? And so trying to move stuff back to the middle and to create that sense of communal belief and trust in the scientific messages, and that comes with starting by training our workforce. The second thing, as Dr. Parodi acknowledged, was just our being out there. I frequently give talks about the importance of us as public health and healthcare practitioners being active on social media. And people will say, well, I don't want to be trolled. It's too much work. I don't have time. This isn't my job. But the thing is that if we're not there, we cede that space to others. So I think we start by training ourselves, and then we actually have to be present. And then the third part is that we need a science around this. You know, Dr. Barbot mentioned some really great studies that have come out. There's a history of work around anti-vaccine movements, but there's been a lot more of it in the last 9 to 12 months, I think, around misinformation and disinformation than we'd seen previously, but we need more. We need to know how to do this in the right way. Those of us in public health believe in gathering data, assessing what the right targets of an intervention are, and then making sure that the intervention works. And I think we can't skip that process just because this is something that has such deep emotion. The last part, to me, is mobilizing the stories. As all three of you have mentioned, right? There's the facts, and then there's the emotion. And, I, as an emergency physician, am able to call on HIPAA-protected stories from my own practice. But I think that some of the things that have been most effective in this pandemic, but also when I look at the work that I do around firearm injury, when I look at the work that many of us do around behavioral health, the things that sometimes create the biggest change, and I'll never forget Art Kellerman teaching me this, one of the giants of injury prevention and emergency medicine public health, that when you show up and have a real story that's honest and truthful and that encapsulates the challenges that we're facing, it's so much more effective sometimes than stats. So to me, it is those 4 steps. They're not easy. We're not going to do them overnight. But the more that we start getting out there and getting involved in doing that work, the better space that we're going to be in a year or 2 years.
Thanks, Dr. Ranney. Patty, I'm going to let you touch on this too, but thinking about it in the context, pivoting our conversation a little bit to equity, a little bit more, even more to equity, because I think it's been integral to some of what we've been talking about. Greg had actually mentioned in his remarks the criticality of health systems and public health working together to drive responses that we hadn't thought about before, and some of that was what had transpired in time along with the pandemic that focused on issues of racial inequity in our society more and more. So in some respects, we have this interesting dynamic. But are there a couple of the questions that came in from the audience touched on this? There's a lot of interest in this, and one of which is ideas of local initiatives that can help reach different communities, both in terms of communication, practical response. So Patty, I'm throwing a whole bunch of stuff at you, but hoping that you can, with your experience in Seattle, talk a little bit about that and then open up the conversation to others as well.
Yeah, great. Thank you. This is such a huge topic, how communication and then dealing with structural racism in the system. How does this all work together? Because building off of Dr. Ranney, I think that one simple place for us to start that we used in Seattle, and you can see it in the press conferences we did early on, is that we used language, and I really worked hard to make sure that I was saying that it was our community. It was, we owned the response. And I think that really played and helped in King County right from the beginning. I wasn't isolated either in the talking points with the county exec or with the media of being in a place where it was like, what are you going to do? And then I would respond, well, I am doing this. But to say we are doing that, and then I always work to bring in a partner, whether or not it was one of our faith-based partners, somebody from the healthcare system, somebody else who was a credible messenger. So there are, everything Dr. Ranney outlined, I think, is exactly where we need to start. But there are some first go strategies. I mean, I was fortunate because I've had a lot of media training, but even in this space, you're walking in a crisis mode. The second thing I would say is we center a lot of conversation on this thought of this divide we have in the country right now. So I want to pivot and talk about a third piece of that, or I'm not even sure it's a third piece. It's prominent to me, and that's that in order to really get to the point of trust, we have to stand in a place as a healthcare and public health system and own the structural racism that we see going on and the fact it hasn't been addressed. One of the things that worked in King County is that in the very early on, after we sort of got life care a little stabilized, we got through that first big piece, we knew that the statistics for the Black, Indigenous, people of color data was going to show disproportionality. So we pulled together a pandemic community advisory committee with leaders from the BIPOC community, the faith-based organizations, as well as our healthcare system and business partners. But the key here is what came out of that was an equity agreement. And this equity agreement guided decision-making in King County and allocation of resources. And it was driven by both the qualitative and quantitative data that we had and the stories that our communities of color brought forward. And we allowed that to be the central focused point on our decision, where we put testing sites, where we opened our first vaccination center, how we deployed our mobile teams. The fact that as a community, we were able to do that and hold that, even though I had a couple of elected officials just feisty with me behind the scenes, trying to say they weren't getting their fair share. It really, we were able to hold to it because the whole system had committed to it. So we've got to find a way to do that and to have that community-driven agreement to really both on workforce allocation of resources, and then when tough times get tough, show up together.
Thanks, Patty. You know, we're running close on time in our discussion, and one of the themes that I'd love to hear from each of you about, as we, and it ties to these issues of the political division, and it ties to communication. But let me just ask each of you to spend 30 or 45 seconds talking about what would you like to see most important to be done to start to rebuild trust. Each of you talked about this in some respect early in your comments, but trust across the systems in the community. What would you most like to see happen? Dr. Parodi, let me start with you.
Yeah, so I'm going to pull on one thread that Dr. Barbot was speaking to, which is the individualism and collectivism. And I think for me, there's like a category within the individualism part here. And there are going to be people that are going to remain individualistic. And what's been striking to me, because I went back and looked at the 1918 pandemic, because I said, was this new? And actually, this kind of stuff was going on back then, by the way. And people were willing to make a decision over their own safety because they didn't want to be told what to do. At the end of the day, we've got to be able to reach those people. And in my mind, I don't have the magic bullet here, but I'm going to reflect on actually what my grocer told me, because he saw me talking about this stuff on TV. He's like, you guys are not being practical. Can you give us just some practical advice for what's most likely to be a problem? And people will generally do that. or they'll be able to convince other people to do that, even if they won't listen to you because you're in a position of authority. And I think that was actually an interesting insight that he gave me, which was that we've got to enlist other people to carry this message, people that look like the people we want to help. And so I'll leave that open to interpretation of what that means. But I think that what I'd like to see is that we, public health, the health systems, are enlisting others to carry this message on our behalf.
Yeah, that's very helpful. Thanks, Steve. Dr. Ranney, I know you've been thinking about this.
I love this. So I'm going to, I think I could talk a lot about kind of how to increase trust among the larger community, but I'm suspecting that Dr. Barbot and Patty will speak about that. I am instead going to talk about increasing trust among our healthcare providers and our public health practitioners, which I think is a really important part of trust. We're not going to get the trust of the wider society until we have the trust of our own. And I think we have to step up and take care of those folks that have been on the front lines providing service to our communities for the last 20 months. Our public health departments and our healthcare systems have just, our workers have gone so above and beyond and are so exhausted, both physically and emotionally. I think we need to do a better job of protecting our healthcare workers and our public health practitioners, both in terms of the very safety basics around ventilation and PPE, but also emotionally. When I look at stats around the number of public health directors, state and county health officials that have stepped down over the past year because of threats against themselves and their families. When I look at reports from my own colleagues in emergency medicine, and they're just getting burnt out by arguing with patients around the reality of the virus, I think we have to rebuild the trust there that our system is set up to take care of them, to protect them, and to enable them to do their jobs if we're going to create trust among the rest of society. And again, I'm sure that Patty and Oxiris are going to talk about how we'll create trust in the rest of society. I'll stop there.
Dr. Barbot.
I'm laughing because creating trust in the rest of society, that's like a huge one. I think a couple of things. One is I agree with Dr. Parodi about simplicity and messaging. And what actually I had written down for myself to remember to mention was the message matters, but the messenger matters even more. It was really one of the lessons that I've learned. And so to take the Omicron example, like people are getting spun up about it, which has reminded me of the early days when people would get spun up about whatever new data point we got about COVID. And the message that I would always go back to is, yes, but it doesn't change the core message that we've been giving you about the importance of masks, social distancing, and staying home. And now we can add, yes, it doesn't change the messaging about the importance of getting vaccinated. And so my hope is that what we've learned and what we've been able to do over this period is enlist more trusted messengers that are reflective of the diversity of our country, right? So at this point in time, wanting to have more folks who are not just speaking to an urban audience, but to a rural audience as well, and the importance of that, given where the transmission curves are going. The other thing I will say in terms of getting back to a level of trust is transparency. Transparency not only in data, but transparency in how resources are being allocated, and having our elected officials basically have the guts to say, you know what? I don't care if you think you're not getting what you think you should be getting because you were used to getting a lot of resources historically. This is where the data tells us people are suffering the most. And it's incumbent for all of our collective health that we provide this community additional resources and spend the time to eventually get people to say, you know what, you're right. It's going to take time and it's going to take resources. But in order for us to get not only through this pandemic, but whatever the next crisis will be, I think it's important for us to get to the point where people have transparency in resource allocation, and an understanding of why we need differences in resource allocation.
Wonderful. Thanks, Dr. Barbot. Patty, I'm going to give you the last word since we're right about time. Some closing thoughts you might have.
Oh, right. Well, the great pearls of wisdom that just came from my colleagues. I just want to say I agree with all of it. And the only two things I'll add is that we need to pay attention to mental health. We won't build trust back if we don't focus on everybody's mental health right now. I feel that we're facing a generation of just trial and PTSD with just everybody, even when I talk to my neighbors. And then secondly, we have to find a way to talk about things, even though the healthcare system is very individual focused. We have to, as a system, public health to the healthcare system, level that up to really talk about it as how that person fits within their community. That needs to be a part of every interaction we all have, so that it's about the social determinants of equity. And that will thread and create a different conversation rather than it's so individual. It's a turn we can take right now. Thank you.
Wonderful. Tremendous advice to all of us. So I want to thank all of you on the panel. Just a really wonderful discussion. It's been great to be able to have you all in this dialogue. And I want to thank everybody for joining us today. We're hoping that you'll be able to join us for part 2 of our discussion on December 2nd. And the intent then is to detail a little bit more around the public policy approaches that could address some of the issues that we touched on some of those today, but perhaps to go a little bit deeper with that. That'll feature John Auerbach, Director of Intergovernmental and Strategic Affairs at CDC, will be in my role moderating, so I'm off the hook for that. And our panelists will be Mary Pittman of the Public Health Institute, Lauren Smith of the CDC Foundation, and Anand Parak from the Bipartisan Policy Center. So let me just thank all of you again. Panelists, you were wonderful. And thanks so much, everybody, for joining us. Have a great rest of the day. Take care.